Good afternoon, everybody. Thank you for joining our webinar. We are pleased to be working in collaboration with the Women's College Hospital to host this webinar on the elder abuse intervention model. I am going to just turn it over to Maeve, who is going to sort of run us through some of the logistics of this presentation and sort of take a backstage. So there is a chat box, just I know Maeve will talk about it, but I just wanted to tell everybody that there will be a chat box. And the one thing that we did add was that there will be handouts. If you look on the side, there's a handout for people to download if you want to follow along on paper as well as the webinar itself and look at the information after. So again, we're really pleased to be working in collaboration on this initiative and research project with the college. So maybe would you like to take it over?
Great. Yeah. Hi, everyone. Thanks so much. So before we get started, I'd just like to go through a few logistics. All attendees are on mute, but can hear our presenters either through dialing in using the number provided to you through the email or by using your microphones on your computers. By the end of the session, as Rand mentioned, we're hoping to take questions. Please submit your written questions in the box below on the right hand of the screen. And once the presentation is over, we'll pose as many of them as we can to our presenters. Also, following the webinar, you'll receive an email linking you to a post-webinar survey. This is very important to us, so please provide us with your feedback so we can improve our future webinars and our project. Now I'd like to turn the floor over to Dr. Janice Dumont, a senior scientist at Women's College Research Institute and the principal investigator of the Elder Abuse Intervention Project.
So thanks everybody for tuning in. It's really a privilege to be able to share some of the work that we've been doing, and we've been doing some of this work in collaboration with Rayanne at Elder Abuse Ontario, and thanks for opening it up, Rayanne. The clinical lead on this project is Sheila McDonald, and she's the provincial coordinator of the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres, and I believe she's online. And I just wanted to introduce Daisy Kosa, who makes all of this possible. She's our project coordinator extraordinaire, and she's actually going to walk you through the presentation today.
Hello everybody, so thanks so much for tuning in. We're just going to go through a little bit of information first about the project. So it's actually funded through multiple sources, so a planning grant from the Canadian Institutes of Health Research, a grant from the Women's Exchange, 15K Challenge, as well as another grant from the CHR. So we're going to go through a bit of background on elder abuse and then talk a little bit about the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres. Then we'll get into the meat of the research program. So we're going to start with phase 1, which is our needs assessment survey. Then go through the second phase, which was a systematic scoping review and multiple Delphi consensus surveys. Then we'll get into phase 3, which was the development of a curriculum for elder abuse nurse examiners and the pilot of that curriculum. Then we'll talk about phase 4, which has been the knowledge exchange, translation, and transfer of some of our findings to date, which this webinar is actually part of. And then phase 5, which is the planned future pilot of the elder abuse intervention under development. Then we'll take some time for your questions and comments. So the problem of elder abuse is very complex. The use of a multidisciplinary intersectoral team is the recommended gold standard for programs, policies, and practices. This is because no single discipline or sector has the resources or expertise needed to address this complex issue. It really is a team effort. A coordinated response comprised of the medical, social, law enforcement, and legal services is necessary to meet the complex needs of abused older adults. Now, here I'm probably preaching to the choir, but we'll just touch on the fact that elder abuse is expected to increase worldwide with the rapidly aging population. And it's fairly common. 4 to 7% of Canadian older adults experience some form of elder abuse or maltreatment. It's a very complex phenomenon. Polyvictimization is common, so that means we're seeing multiple types of abuse in the case of a single victim. And there are very few comprehensive health service responses available for elder abuse that have been developed globally, let alone evaluated. So that brings us to what we might have in Ontario that might be able to offer a comprehensive response or begin to offer a comprehensive response. So the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres was initially funded in 1984 by the Ministry of Health and Long-Term Care to address the acute sexual assault of women, men, and children. It's now expanded to 35 hospital-based programs across Ontario, serving both urban and rural areas. The mandate has been expanded to address domestic violence following a needs assessment survey and independent pilot project. The network also has a long history of innovation. So there are 2 large prospective multi-center research studies that have been conducted by the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres in collaboration with Women's College Research Institute. These include the HIV counseling and post-exposure prophylaxis study, which has resulted in that program being funded across the province in all the centres, and expanded services to victims of drug-facilitated sexual assault. The Ontario Network of Sexual Assault and Domestic Violence Treatment Centres are staffed by specially trained nurses called sexual assault nurse examiners who have extensive training in specifically meeting the needs of victims of sexual assault and intimate partner violence. They are also sometimes staffed by nurse and physician teams. The specialized services these centers offer include crisis intervention, medical assessment and treatment, testing and prophylactic treatment for pregnancy and sexually transmitted infections, including HIV, the collection of forensic evidence, risk assessment and safety planning, referral to on-site follow-up care and short-term counseling for individual and/or groups, and referral to various community agencies for other forms of support. However, the network does not currently offer a standard province-wide provision of dedicated care for abused older adults that is comprehensive, that is, addresses all the various forms of elder abuse. The SADVTCs do, however, provide care currently to those age 65 plus who have been recently sexually assaulted or are a victim of physical assault by an intimate partner. So this led us to initiate this elder abuse intervention project. So building on the existing infrastructure of Ontario's SADVTCs, our goal has been to develop, implement, and ultimately evaluate a comprehensive multidisciplinary hospital-based elder abuse intervention that has formalized link to allied health professionals and collaborators in the community and legal sectors. So this phase diagram has lots of text on it, but we're going to sequentially go through each phase. Just briefly here, we've got our phase 1, which was our needs assessment survey. Then we gathered recommendations from the literature and evaluated them in phase 2. Then in phase 3, we developed some training for our sexual assault nurse examiners specifically for elder abuse. And then in phase 4, we shared our findings and developed a template intersectoral protocol. And we're looking in the future about how to pilot this intervention. So phase 1, establishing the perceived need for and feasibility of elder abuse programs of care at Ontario's sexual assault and domestic violence treatment centres. So the needs assessment survey was phase 1. Our objective was just to evaluate whether or not this was something that the network centers could potentially do and should do. So in July 2012, a survey was conducted of all the program leaders for Ontario's SADVTCs, excluding those centres that serve pediatric populations only. And more than 4 in 5 program leaders favored expansion of their mandates to include a comprehensive elder abuse care program. They suggested that this would actually enhance services overall and better utilize the expertise of sexual assault nurse examiners. However, they did suggest that there were certain things that would be necessary in order to establish such a comprehensive elder abuse program of care. And the thing they most strongly identified, 91% of them actually, is identified that an established coordinated community response network would be imperative. They also identified that specialized training of elder abuse, specialized training of sexual assault nurse examiners would be necessary to allow them to provide complex, comprehensive care to abused older adults. They identified particularly a need for further training in existing legislation. So this led us to our second phase, in which we went to the literature and gathered and rated recommendations relevant to a hospital-based elder abuse intervention. And this phase was funded by CRHR. So we conducted what's called a systematic scoping review, which was not just restricted to scholarly literature. It also included a wide range of documents from the gray literature. And what we were looking for, our objective, was to find recommendations relevant for components of care, participating professionals and their roles and responsibilities, as well as guiding principles and determinants of health. And this publication is actually available online, and it is open access. So you can see here, this is our very, very rigorous literature search. It was extensive and included 168 documents that were full-text screens from the gray literature and 2,524 scholarly citations. And we ended up with 68 unique responses that met the inclusion criteria. So from those responses, we extracted 299 recommendations that were relevant to a nurse examiner-led hospital-based elder abuse intervention. 109 of them were professionals and their roles and responsibilities, 30 were the guiding principles and determinants of health, and 149 reflected the components of care. However, only a small portion of the responses from which the recommendations were drawn had been pilot tested or evaluated, less than 10%. So we undertook to evaluate these recommendations in a modified Delphi consensus survey. The first one of which comprised of the recommendations, 109, for professionals and their associated roles and responsibilities. And we drew on a panel of 26 intersectoral experts. And this panel was very diverse. You can see here, this is a representation of all the different professionals that were included on the panel. So that percentage represents what fraction of the panel was subscribed to that profession, and you can see they're non-mutually exclusive categories. So we had some individuals who are representing more than one profession here, and they met in person and on June 16th, 2014, and we worked them very, very hard. We asked them to review and rate and debate and then re-rate many recommendations in person. And then we also followed up with them on an online survey. So if anything didn't reach consensus in that first meeting, we re-rated it online. So we ended up with this model, and this model is the professionals that would be included in a hospital-based elder abuse intervention. And you can see here that there's these little dashed arrows between some of the bubbles there, and those dashed arrows represent professionals who are rated for roles and responsibility that are sometimes the same or similar. So depending on the resources available in an individual community, they might be interchangeable roles. And you can see there's a lot of professionals that might be necessary, depending on the case, to meet the complex needs of abused older adults. We also delineated the individual roles and responsibilities for each professional. Then separately, we evaluated the recommendations for guiding principles and determinants of health. So remember, there was 30 of those, and we had them evaluated by an expert panel of 12 program leaders from Ontario's sexual assault and domestic violence treatment centers. So this was an in-person meeting as well. And what we're trying to do with these guiding principles and determinants of health is build a social inclusion framework that underlies the elder abuse intervention and promotes equity and access for particularly vulnerable or marginalized groups. So some examples here, 18 of the 19 guiding principles extracted from the literature were deemed important to the elder abuse intervention, which really just speaks to the breadth of recommendations from the literature and how important they ended up being when we talked to hospital-based program leaders. So some examples include all older adults have the right to be safe, all older adults have the right to appropriate protection, and older adults should never be held responsible for the abuse they have experienced. Additionally, 11 of the 11 determinants of health were deemed important to the elder abuse intervention, and very unanimously. There was one addition, which was history of abuse and trauma. So you can see the full spectrum of determinants of health that were rated as important as drawn from the literature, and additionally the added history of abuse and trauma in the left corner there. So finally, remembering that we still have remaining the components of care, we still had to evaluate these components of care for their potential importance to the elder abuse intervention and development. So 148 recommendations of the initial 149 were reviewed by an expert panel comprised of 30 program leaders of Ontario's SADVTCs who have extensive clinical experience in delivering hospital-based violence and abuse services. There were 2 online surveys conducted, and all the recommendations were rated or re-rated for their importance to the elder abuse intervention on a 5-point Likert scale. So based on their ratings, 119 of the 148 recommendations drawn from the literature were rated as important. And they were organized thematically into initial contact, capacity and consent, interview with older adult, suspected abuser, caregiver, or other relevant contacts, the assessment, which comprised of a physical/forensic assessment, mental, psychosocial, and environmental and functional assessment, and then a care plan. The program leaders, experts, were also asked whether they found that the recommended components of care could potentially fall within the scope of practice of an elder abuse nurse examiner, so someone who had received additional training to meet the needs of abused older adults, because we recognize that many of the items that could have been rated as important might not be within the scope of practice even for a fully trained elder abuse nurse examiner. So 101 of the 119 recommendations were deemed as potentially within the scope of practice of an elder abuse nurse examiner by the majority of experts. So that took us to phase 3, which was the development, piloting, and evaluating of the elder abuse training for nurse examiners. So we took, remember, those 101, which were rated as potentially within the scope of practice for elder abuse nurse examiners, and we developed them into 47 skills-based competencies, which have been used to guide the drafting of an elder abuse nurse examiner curriculum. And this curriculum includes a manual, a PowerPoint training aid, and a facilitator's guide. This training builds on existing sexual assault nurse examiner training. So this training is specifically for individuals who are already SANE trained. And this curriculum was piloted on October 2nd, 2015. So it was an 8-hour in-person training led by experienced SANEs who also have additional expertise in elder abuse. The curriculum is split into 6 sections, included case studies, PowerPoint quizzes, a printed manual, and a pre- and post-test evaluation. So you can see here our competencies were categorized into meta competencies. So documentation, legal and legislative issues, the interview with the older adult, caregiver, and other relevant contacts, the assessment, medical and forensic examination, case summary, discharge plan, and follow-up care. So following the pilot, we evaluated and analyzed the data from the pre and post test. And you can see that the results are quite impressive. So if you look at older adults and abuse, which is the top line there, they showed a significant improvement in their knowledge related to older adults and abuse. And in the second item, documentation, legislative, and legal issues, they showed a highly statistically significant improvement in their skills-based competency related to that area, which, as we remember, in the phase 1 was an area where program leaders identified a particular need for additional training. But they also showed statistical improvements across all 5 metacompetencies. So now we move into phase 4, which is knowledge exchange, translation, and transfer. So our objective in this phase, which was funded by the Canadian Institutes of Health Research, was to share the development of the elder abuse intervention to date and to discuss the development of a potential intersectoral protocol for collaborating with allied healthcare and the community and legal sectors. So remember, this arises from, again, our phase 1 needs assessment survey from the identified need for a coordinated community response network. So this meeting was held on October 1st, so actually just before the elder abuse nurse examiner training pilot, the day before, and we gathered together 22 experts from across multiple sectors. So if you look at the logos here, this is the groups that were represented at that meeting, and there was a large diversity of service providers and policymakers there, as well as some academics. And they identified, and we worked through it throughout the day, possible components and content of a template intersectoral protocol. So they suggested it would be important to have goals and a mission statement that was shared amongst all the intersectoral collaborators, which could be driven by the guiding principles and a framework of social inclusion that we talked about earlier. Some operating principles, so how to support and maintain a working relationship between the participating organizations, delineating collaboration and service provision, so particularly important the level of commitment and range of services each organization would be providing, the procedures for sharing information, so in terms of the importance of not only obtaining informed consent from the initial service for the provision of the information to the initial service provider, but as well as for the sharing of that information with other service providers from the older adult, and concerns about privacy and confidentiality, assuring that's always maintained when we're collaborating as a group, and that no breaches of privacy and or confidentiality of the older adult could occur. Conflict resolution, so ways of mitigating and engaging in any possible conflict that might arise between participating agencies, and the processes for referral. So how do we refer from the community potentially or helplines to the SADVTC from within and outside of the hospital, and what the criteria for those referrals might be, and also referrals from the SADVTC to other professionals within the hospital as well as in the allied health community and legal sectors. We also attained some recommendations from the intersectoral experts for further knowledge sharing. So they suggested hosting webinars like this to share our findings more broadly. They also suggested developing other knowledge translation tools and materials, which we have done. A video is currently under development. It should be completed by the end of next week. We have 2 infographics developed as well as an executive summary and brief. These will be distributed and shared on a future date. So moving on to our final phase to be talked about today, and that's the evaluation of the elder abuse intervention for its impact on short and longer term health, psychosocial, and process-related outcomes. The plan is to pilot the elder abuse intervention at 4 sites, so 4 hospital-based violence treatment centers in conjunction with the local elder abuse network from that region for the intervention's acceptability, feasibility, and the satisfaction of patients, providers, and community-based providers with the intervention, as well as the fidelity of the implementation of the intervention. So these are all specific outcomes for pilot studies. Potential pilot sites that have signed on and expressed keen interest as well as an ability to get their hospital administrations to commit to the pilot of the elder abuse intervention are Brantford, Thunder Bay, Waterloo, and Toronto, which is specifically Women's College Hospital in collaboration with Mount Sinai. We want to implement and evaluate the intervention province-wide ultimately, and evaluate it for its impact on short and longer-term health, psychosocial, and legal outcomes. However, we need to secure funding for these evaluations. Thank you very much for listening. We hope you will continue to support and collaborate with us going forward by completing our post-webinar survey, and I'm happy to share any of the publications mentioned here with you, so you can contact me directly by email. And once again, we want to acknowledge that this is not ivory tower research. We really appreciate the engagement of the community in this research program to date and their support.
All right, thank you so much, Daisy. So I was just wondering, now I want to open the floor and see if anyone has any questions for us. So I'm going to open the question box here, or I'm in the chat box, and feel free to type in any questions you might have for Daisy. No questions? Also, if you want to take a closer look at these slides, because there's a lot of content in there, a lot of really important content, you can download the handout on the right side of your screen where we have the April webinar 13th. So you can look at it more closely, and of course you can look at the publications, which you can see are quite extensive. Here's a list of references that Daisy was referring to, and you can look all these up.
Sorry, we just have a question raised. It's Rochella. Kathy, if you can, I just unmuted you. I don't know if you're using your computer or the question box, but you can type your question. I just see that your hand's raised, so I've unmuted you if you want to ask your question. Okay, so I see a question here. I thought there was some sexual assault, domestic violence centers that had already piloted this.
So in answer to that question, one of our programs in Renfrew has actually developed and has really sort of spearheaded the development of a elder abuse intervention at their center, and they've been very, very successful, and Jen Valaket has been instrumental in guiding us in this program of research. So that's why they're not actually a pilot site, because they're already doing it.
Okay. I'm just going to see if there's any other questions.
If I can just add to that program that you just talked about in Renfrew, that's been going on, as Daisy said, for quite a while and has received funding. I do believe they received funding too through the LINS as part of that project initiative, and it's very successful. And we've actually did have Jennifer on one of our webinars just recently just talking about that initiative.
Okay, we have another question here. How long will the pilot be, and will other centers be added in?
So the pilot of the elder abuse intervention, we don't have funding for it yet. So as of this date, we don't have a timeline for that pilot because it would be funding dependent. However, if there were other centers that were interested, which there was several centers that expressed interest, it really would be funding dependent on whether we could include more.
maybe there's another question, and Daisy, what kind of elder abuse network support do you need in the community?
So there's actually a publication which I'm happy to share that was in PLOS One. So it's the Delphi Consensus Survey on the Roles and Responsibilities of the Participating Professionals. And basically we would need support from the allied health community and social services sector on all of those roles and responsibilities, because we don't have those professionals in our centers. So we're looking for quite a lot of support from the community, and that's why this intersectoral agreement, which would have to be established in the advance of any pilot, would be very important. Yeah, so this is a proposed model elder abuse intervention, and ultimately it may look very different from community to community depending on the available resources.
Okay, and there's another question here. When you mention funding, where would the funding come from?
So we're looking for funding. So we are welcome any ideas where that funding for the pilot might come from. So we hope to be able to apply for any upcoming research funding opportunities, and may actually seek support from any agencies that would be willing to write us a letter of support for such a pilot at these 4 centers.
Someone also was inquiring about how long the pilot would go on for.
So that would really depend, the length of the pilot, on the number of centers we would be involving, because you need to obtain ethics board approval at each center. Additionally, it would depend on the rules of the funding agency. So, you know, we had planned initially in our protocol a two-year program.
And there was another comment, why was the model developed with a nurse led when a social worker already has the relevant knowledge and training?
Hi, sorry, this is Janice. The way this project originated was really around the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres expressing an interest in expanding their mandates to include care and treatment of women and men who've experienced elder abuse. So that is already, for those of you who don't know, that is already a forensic nurse examiner model that provides care to men, women, and children who've experienced sexual assault and intimate partner violence, but no comprehensive kind of response to elder abuse. So it's always been with the idea that we would build on the infrastructure of the existing services of the Ontario Network of Sexual Assault and Domestic Violence Treatment Centres, but obviously it takes more expertise and more collaboration to really do a proper job on elder abuse, and that's why we sort of began looking at the literature, talking to experts such as Rayanne at Elder Abuse Ontario. She's been part of sort of the development to develop something that's much more comprehensive and that has formalized links to the appropriate people in the community and legal sectors. However, social work does play you know, an important role in the entire model that we're proposing.
Are there any other questions? Oops, sorry, go ahead.
There's one here. Is there any plan, assuming the pilot goes ahead, of EA nurse examiners doing community or home visits?
Not in this particular model. I think there is a model, there is a program, I believe, in Renfrew. One of the SADVTCs has already developed their own particular response to elder abuse in that jurisdiction, and if anybody's interested in that, it's Jennifer Veliquette, sorry, Jennifer Veliquette could tell you more about that. She's the program leader of that particular SADVTC, and they do actually do home visits.
And I think you might have already answered this, but it says, do you receive grants to help these pilot projects? So it is dependent upon funding.
Yeah, so basically my role in this entire project is a researcher, and I've been collaborating with Sheila McDonald, and I think she's online for probably over 15 years, trying to improve upon the services in an evidence-based fashion that are provided by her network. So we do always look for grant-related funding. It's very tricky to find funding for intervention research. It's a hard type of research to be able to get from granting agencies, but we're always looking and attempting, and we are, currently in terms of hopefully being able to move forward with the pilot. But yeah, it's contingent upon securing some kind of funding.
Great. And there's another question here. Have you developed a draft of what an intersectoral agreement would look like to formalize support from community partners?
We had a meeting back in October that involved Rayanne from Elder Abuse Ontario and several of the chairs of the Elder Abuse coordinating committees from Ontario and other key stakeholders in the elder abuse area from not just Ontario but from across Canada. We also had Pat Power from Edmonton and Mark Gaffey come in from Montreal and stuff to talk just exactly about that. And we prepared a little meeting brief that sort of summarizes what happened at that meeting that we'd be happy to send anybody who's interested. So we did sort of come up with what the key components might look like of an intersectoral protocol, but we don't have, an exact sort of protocol laid out yet. And I think part of what we envisioned as the pilot would be to sit with the various groups in the pilot communities to sort of hammer out the sort of specific details in that, that would work in that particular community. As Daisy said, I don't think the model would vary drastically from community to community, but there could obviously be changes depending on available resources in the community and also who's available in the hospital. So if you'd like any materials, Maeve can be emailed, and we can provide various different things if people want a copy of a paper or the intersectoral meeting brief or any of those things. We're happy to provide them.
So there's a question here, curious about supports, especially legal, for offenders of elder abuse / mistreatment who are living with dementia, especially in light of mandatory charging for spousal assault. Do you know anything about this? So I'm guessing persons with dementia that might have responsive behaviors who are dealing with the justice system and dealing with spousal assault or domestic violence. Do you have any specific content or information?
Yeah, so part of the model includes having a caregiver advocate. And I don't think that addresses 100% of sort of the issue being raised, and certainly we recognize, and we've had sort of experts involved along the way that, especially in the context of institutional kind of elder abuse, that much of it can be resident to resident and involve issues such as capacity and consent and, in the context of dementia, et cetera. So I don't have much more to say specifically about that right now, other than we're sort of aware of some of these issues, and we did feel that in the model, and based on the evidence that we could find out there, and we reviewed interventions globally actually to help inform this particular model, that a caregiver advocate was important for some of those reasons, and also having legal supports available. Rayanne, did you have anything to add to just general knowledge about that that you wanted to?
Well, I mean, I guess Rochelle might even be able to add to this as well, that we recognize that is an issue around domestic violence currently, and has been in the past, but more so, I guess, probably in the last year or two.
We always look at intent.
Go ahead.
You know, I'm just saying one of the things that we do is we work with Behavioral Supports Ontario. Some of our regions have court diversion projects. So I know Guelph has a new project called Safe Pathways. In Hamilton, they have a forensic team that specifically works with those who might have a dementia, might have a brain injury that impacts their capacity, as well as people who are incapable under the Mental Health Act, who at the time of the offense might have been experiencing a delirium, might have been experiencing something that was medically related. And so when we look at those situations, we look at intent, we look at the whole situation, and there's, you know, like I said, each region has might not have a specific court diversion project, but I know NICE has done a lot of research. They've addressed the resident-to-resident aggression. They've talked about the statistics, and it's a huge issue, and really it comes down to the long-term care home or retirement home that has a duty to provide a safe environment, that has a duty to have an appropriate care plan, and has a duty to train their staff specifically in the needs of that resident. And so it's working with the facility to call in the appropriate resources, like a psychogeriatric resource consultant or BSO, to come in and assess what could be causing those responsive behaviors.
And I'll just, thank you very much, and I'll just add one more thing. In the model we're proposing and sort of the professionals and the sectors involved, it doesn't mean that we wouldn't be also referring beyond that where appropriate in a particular case. I mean, one of the parts of this model is having some kind of case review to make sure that all the necessary needs are kind of being addressed by the core team or beyond the core team if necessary.
I just in terms of also the perpetrators and you know, the victims as well as the offender, whoever has the dementia or mental health issues, that there are some other models being developed through domestic violence committees or for like age, issues around seniors at high risk. So there's like the Aged Heart program in Durham region, and I know York region. There's a couple other that are looking at a different model in terms of addressing those specific issues. And there's additional training that's being done through the police. You know, there's an upcoming Ontario Police College that's hosting their 3-day conference, and domestic violence and issues around dementia and capacity. All these issues are being further trained on in terms of increasing people's capacity to respond appropriately.
And NICE was mentioned, and I do know that Lynn McDonald, who is part of one of our original grant applications, who's done the work on resident-to-resident abuse, is looking at the importance of sort of bringing experts together as well to discuss what kind of interventions, you know, are necessary to deal with that particular issue within, you know, sort of residential care, given that it is quite a staggering problem based on the research that she's done already.
Sorry, there was just another comment. Yes, or it could be a cycle of domestic violence, but they're not known to police. So that was just a comment somebody had. So I guess even if they had a cognitive issue, they might have previously had a history.
Mm-hmm.
Would an older adult experiencing financial abuse, but not physical or sexual abuse, be seen in this model? 50% of elder abuse is financial.
So typically the way we think that this would probably occur is that somebody would probably actually present in the emergency department. So if somebody was only experiencing financial abuse, we don't think that would necessarily be appropriate for them to be brought to the, you know, to the hospital. However, we are, the model does address financial abuse because it may be, we know there's a lot more research coming out on polyvictimization, so that, for example, these, you know, the various types of abuse rarely occur independently. So it may be that somebody's brought in specifically because elder abuse is suspected or it's identified in the emergency department, or a call is made to a sexual assault nurse examiner in one of the wards or something. And it's for something specific, maybe physical abuse, but financial abuse may be part of the package, and we would be prepared then to address that and do the appropriate referrals to the bigger team in the community. It's a good question.
There's a question here. Are those interventions Hamilton Guelph through BSO?
Those are the ones you refer
to. I'm not, I'm Mary, if you're referring to the Safe Pathways in Guelph, that is actually a partnership between CMHA, Canadian Mental Health Association of Guelph, Alzheimer's Society of Guelph, and I believe a couple of other partners that are working on that. In Hamilton, it's St. Joseph's Hospital, and yes, both of them partner with Behavioral Supports Ontario. I'm not 100% sure who the main lead is in Guelph, but I know that CMHA is one of the leading partners. So if you have further questions, you can just email me and I can give you the contacts. And there's just a comment, thank you so much. And I'm not seeing any other comments here or questions.
If we're going to conclude, I'd just like to say thanks very much for tuning in. We really appreciate the interest in the intervention. Hopefully, you know, it'll continue to evolve as a model. Hopefully we can pilot it in collaboration with some of you. We'll look for funding. We'll keep you posted. We're happy to send any documents you'd like from the reference list or the meeting brief about the intersectoral protocol, so just please let Maeve know. And we would be absolutely thrilled if you'd be willing to complete the survey for us. It sort of helps us understand who's interested and who sort of participated. We don't care about specific names, but you know, what sector you represented or a community service, etc. So it's very helpful to us if you're willing to take a couple of minutes to do that. There's only about 5 or 6 questions, I believe, and they're like fill in, you know, you just tick off a box. Rand, did you want to close?
Oh, sorry, I was just unmuted. Was there one more question? I thought I saw a hand up.
There's comments. People are saying thank you very much. Good luck with funding. This has informative, and they will be sharing this among their SAFE subcommittees. So just, yeah, just some comments there.
Great. Well, I would like to thank Daisy for doing the presentation, as well as Janice and Maeve for also participating and giving us a great overview of the project. It's been a very interesting initiative to be involved in, and we hope that the funding does come through so we can continue the work that we are doing. And again, as indicated, you can download the presentation. If you're having any difficulties after, in the survey, there should be contact information for Elder Abuse Ontario, my email, and if not, then you can contact our head office and we can make you get the connection information to for emails to if you want those further information from Daisy and Janice, we'll send that links to you as well. So thank you, everybody. And next week, just as a reminder, we do have a continuing with our domestic violence series, we have a webinar on the 19th on safety planning. So if anybody's interested, you can sign up for that as well.
Just disconnect.